Hi everybody and welcome to Cooking from the Heart. We're in Los Angeles today, and as all of you know, we were out here filming and talking with my cardiologist, and one of the biggest things that they wanted is, obviously that she's been wanting me to do is to get the exercise in. So this was one of our favorite places to come and walk when we were living here, and it's very frequent by, quite a few healthy people, and so we're trying to be part of those healthy people now, and so we're going to go out there and take in the walk, and the climb down is not as bad as the climb up, and that's what we need to work on. So here we go, we're going to go exercise. So we ventured off up into the mountains here, and it was just a really beautiful day, and the views were just awesome from up on Runyon Canyon. And then we took a second day where we actually really hiked up the Hollywood Hills, which I had never done as many years as I lived in LA, and it was really nice. I spent the day with my sister and her dogs. And of course, the main reason I was there was to see my doctor and do my follow-up. And we're going to probably do this in 2 episodes. I have a follow-up conversation with my cardiologist, Cynthia Thyke. And in the second episode, we're actually going to take cameras in as I'm having my stress test. And this is what happened with my doctor.
I'm Dr. Cynthia Thyke. I went to medical school at University of Chicago and did my internal medicine and cardiology training in Boston. I was at the Harvard program, the Beth Israel, and then the Brigham and Women's Hospital and the Massachusetts General Hospital for cardiology. I finished there in 1997. I've been in California since. I was on staff at UCLA for a couple of years. I worked mainly there with the heart failure and transplant program, and have been in private practice since 1999. My mom's a doctor, and so I always knew I was going to be a doctor. When I was in medical school and then in my residency for internal medicine, I like the acute care of cardiology. I mean, I like being in the intensive care unit doing the procedures. I'm sort of a scientist at heart, and so the physiology and the hemodynamics made sense to me, and so I was intrigued by that.
Now, I noticed on your card, though, that you say you specialize in women's.
As you know, and we've talked about this, heart disease is the leading killer among both men and women. But until really recently, particularly with the campaigns that the American Heart Association has done with the, Dress for Red and Red Dress campaigns for the heart, the focus really hasn't been on women and cardiovascular disease. I mean, it's always been thought of as the disease of the men. And while it's true that more men have cardiac disease and die of cardiac disease at a younger age, that's only because of the lag time that occurs in women as far as their diagnosis. Women tend to present with more atypical chest pain, and oftentimes both the patient themselves, the females themselves, as well as the doctors sort of brush it aside and attribute it to other etiologies. And being a woman myself, I felt that it was important for me to really sort of spread that word and to make it comfortable for females to come to me and tell me about symptoms that maybe they mentioned to their physicians in the past and it's been brushed off or not really thought seriously of, and tell them that no matter how minor the symptoms, no matter how atypical the symptoms, is worth getting evaluated.
Pretty much what happened to me is, I'm grateful that, the physician that sent me to you picked up on signals and signs that I had been mentioning to other doctors, as you said, that were kind of overlooked and kind of pawned off as it being menopausal.
Right, and fortunately for you, you didn't have anything serious, okay? But when you look at your risk factors and your family history, the fact that you have diabetes, high blood pressure, high cholesterol, that alone warranted an evaluation.
Right.
Well, we talked about the fact that your heart muscle was thickened, okay? And at the time I first saw you, I don't even think you really had the diagnosis of high blood pressure, or you weren't on medication. And so I remember we did the impedance cardiography, which is a test to look at the internal hemodynamics of the heart. And then we did the blood pressure monitor on you. Remember the monitor you wore for 24 hours? And that was, I think, somewhat shocking to you to see.
It was interesting and shocking.
where your numbers are throughout the course of the day. Because all too often, I get patients, when I tell them that they have high blood pressure, come back and tell me, no, I don't. My blood pressure is always 110 or 120 when I see a doctor, or when I check at home, it's always 110. They forget that blood pressure is not a static number, it's very labile. And oftentimes when you're checking at home, you're in your relaxed environment, or when you go to your doctor's office, after waiting a half hour reading a magazine, you're nice and relaxed. But that doesn't reflect your entirety of your life.
No, I think there's a lot to be said about things that we don't understand during that, when we're thinking we're in relaxed states, that we're not always there.
Different people have different, triggers, different stimuli. Yeah, and oftentimes you don't know. I mean, hypertension affects 70 to 80 million Americans, and the statistics, even our current statistics, shows that probably less than half are diagnosed, treated, and controlled. Okay, so it's still a disease that is very underdiagnosed, underrecognized, and even when it's recognized, it's not fully treated. Yeah. And part of the reason for that is that when you go and see a primary physician, they have limited tools. I mean, the only thing they have is the blood pressure cuff. And we've already said the blood pressure is labile, and so more often than not, you're going to sit in the valley of your range. And so, as a cardiologist, I'm fortunate because I have much more tools available to me, like the ultrasound that you had, which shows the thickening of the heart muscle, or the ICG, and so I can see structural changes and that reflect a constant or continuous blood pressure range that the primary physicians don't have access to.
I just keep wondering, as much as I'm running around and doing whatever, I can run rings around everyone else. But it's not, the exercise or trying to fit in that 20 minutes nonstop is sometimes really difficult to do after a long day. It's trying to find that balance all the time. Every person is kind of different in that sense, because I don't think I'm still. I think I'm really careful what I'm watching, what I'm doing, and whatever, but can't seem to get the weight off.
And you make a really, really good point that I want to emphasize, okay? While it's true that dietary indiscretion is what has led some people to their current situation of obesity, I think it's equally true when obese patients say that I don't hardly eat anything. I'm out to exercise. I'm doing all the right thing, and yet I can't lose the weight. I mean, there is truly a metabolic disturbance that go on within the body, both in terms of insulin resistance, hyperinsulinemia, that then leads to high blood pressure and high cholesterol. And because insulin, even though it's a very useful and vital hormone in our body, it also does a lot of negative effect, especially when people develop insulin resistance, and then there's hyperinsulinemia. It has adverse effect on the kidneys, as far as causing the kidneys to retain salt and water, which we know is one of the biggest mechanism of hypertension, right? And so that's why you're on a diuretic to get rid of the salt in the water, and most patients with hypertension are on diuretics. Insulin affects how fat is transported into the muscles and the fat cells, leading to hypercholesterolemia. And so there are many of the risk factors that we talked about in terms of high blood pressure, cholesterol, and diabetes are all tied into insulin resistance and hyperinsulinemia. Basically, by turning off the pancreas, by shutting off insulin production, giving all your organs a chance to relax, to be free of insulin. And then we reintroduce in a slow fashion. We reawaken the pancreas. We allow the resecretion of the insulin, but in levels and bursts that the body and the organs know how to handle it. When you pay attention, when you put a focus on it, when you actually say, I'm going to do this for myself because it matters, I matter, then that's when you'll make the difference.